Okay, good afternoon, folks. Welcome to our town hall for today is Thursday, the 11th of June. I'm Bruce Squires, Vice President of Women's and Children's Health, President of the Children's Hospital. Thank you so much to everyone who is joining. I'm just noticing I need to work on my lighting here. I'm only lit up on one side, so I'll see if I can do something better in terms of this location. But I want to thank everybody for joining. This is we're into double digits for our town halls, and so we hopefully are learning and getting better as we go. I want to acknowledge. Actually, before I go there, that we're following the HHS Town Hall by Rob McIsaac and other members of the leadership team that just finished up. So a number of folks may join following that. A number of folks may not join us today because you chose the bigwigs over this one, which I would certainly respect and understand. A couple places I might refer to some of the updates that Rob and the team provided as appropriate. So welcome. We have been evaluating, so you do get an evaluation after every meeting. Smaller number completed it last time. We had 34. Our value score was quite high, up in the 96 percentile rating. So we're still going in the fact that folks like it, but fewer people filled it out, which again I understand. One of the pieces of I think very constructive feedback was address all questions as they are asked, not just ones specifically picked and especially picked. And so that's a fair criticism. I am challenged a little. I'm finding a challenge a little bit in trying to get through every question, and so sometimes looking to try and combine them so that I can get to more content. But in doing so, may have overlooked key pieces. So I'm going to try and re-engage on providing answers to questions that we haven't answered in the town hall during the follow-up and through posting. So that's a very fair comment. I also had one that said I should have answered the chat post, and so again I do apologize for that. I had trouble kind of managing both pieces, so I'd really invite you, if you're online now, to re-ask that, maybe through the chat or even ideally through an email directly to me. So I promise I will answer that. Another piece of feedback was we love our guest speakers, and we love our guest speakers on topics like where are we going with virtual care. So really pleased to welcome Nate Vandendoel to join us. And I've had the pleasure of working really closely with Nate in the past, but particularly over the last, it's like 8 or 10 weeks now, because I've been able to be part of the virtual care task force. And Nate really is the individual at HHS that has been driving our work on an ongoing basis, and then particularly through the pandemic. Nate is a clinical manager in ambulatory care, but really has been focusing on this file. So I'm going to turn it over right away to Nate. We've kind of given him some framework around the questions that have previously been asked, and then just asked him to share a little bit that kind of relates to where we are and where we're going into questions. So Nate, thank you very much for joining us. Welcome to this friendly group, and please go ahead.
Great, thanks very much, and thanks for the introduction, Bruce. It's good to be here. And certainly, as you've been involved in the task force and in leading that work, specifically related to virtual care, I trust that if I miss anything or if there's anything else you'd like to highlight, that you can kind of pitch in as well. And so I'll just start with a little bit of an overview. There were a couple of questions that I was sent in advance, and I'll try to get to those as well. And then certainly, if there are other specific questions that others want to ask, happy to address those as appropriate. So just to start in terms of, some of the context around virtual care. So we have been doing virtual care at Hamilton Health Sciences for quite a while now. And one of the things I always like to start with in talking about virtual care is what the definition of virtual care is. And so I'm not going to kind of read a specific definition, but ultimately what it is leveraging different forms of technology to connect either providers to each other or providers to patients and vice versa. And so it's a very broad term, and certainly would include things including phone visits and mechanisms to deliver care that way as well. And so in that context, we have been doing virtual care for quite a while. More recently, within the last about year and a half, we've started kind of layering video into that a little bit more than had been before. And then, of course, in the context of the pandemic, and the inability to really connect with patients in person as we had done so much before, did a lot of a huge shift to virtual. And that's evidenced in some of our numbers as well. And so I think the last metric I saw was about 2/3 of our visits, our ambulatory visits currently, are being done virtually, whereas about a year ago we were probably somewhere in like the 1.5 to 2% mark of total ambulatory visits being done virtually. And so I think that speaks to the transformation that's happened with respect to virtual care, and ultimately what you have all done in terms of making that happen and being able to continue to deliver care to our patients in new and innovative and creative ways. And I know sometimes that hasn't always been easy, and so want to recognize that, and that's certainly kind of forming some of our thinking at the task force with respect to how we want to move virtual care forward at Hamilton Health Sciences. And also helps us understand what we need to do differently to support this. And so we definitely see virtual care, including things like telemedicine, remote patient monitoring, things like patient portals, e-consults, and everything in between, as being a part of how we're going to deliver care in the future. And certainly it's being done now in many respects. It definitely aligns with our strategy at Hamilton Health Sciences, and it has the potential, as we've seen during this time, to deliver value to our patients, our families, and providers like yourselves. And so, it's important, if we want to continue in this work, that we provide our teams and caregivers and patients with the tools and the support that's required to do the work in this new and different way. And so there are a few things that we've done to do this. One, particularly in the last 8 to 10 weeks or so, as Bruce has alluded to, is we've created the Virtual Care Task Force, which is kind of a means to strategize around how we want to move virtual care forward, prioritize some of the work that's coming through, and then assign resources and support the work where that's required as well. One of the things through the virtual care that we've done is developed our HHS virtual care standard operating procedures. And so maybe, I'm not sure what mechanism there is, but Bruce, maybe somebody could send out a link to that to folks, as an opportunity for you to take a look at it if you haven't. And really the idea there is to kind of highlight some of the high-level processes anyways with respect to what needs to happen around delivering care virtually, and then also recognizes that there needs to be some flexibility because people work in different ways, and we need to consider that, and so happy to support folks in different ways also. So talked about the Virtual Care Task Force, the standard operating procedures, and then another key component is resources. So one of the things that we're looking at as a task force and as an organization is looking at creating the right supports to be able to help you and our patients making successful transitions to virtual care, to ultimately ensure that there is value, because we don't want to do it if there isn't, and to ensure that there's a good experience so that people want to keep doing it as well. And so, we recognize that a lot of this has to do with some of the processes and integrating new steps seamlessly into workflows so that it's easy to do. But there's also a component of technology with respect to that, and that's one of the questions that people asked specifically was around, a lot of our computers at HHS, for example, don't have the mechanisms to, whether it be microphones or cameras, to allow staff to participate in virtual care. And so certainly that's an important consideration. As many of you know, there is a ongoing strategy related to the digital health plan around computer replacement across the organization. Um, that said, the desktop computers still don't have webcams and stuff like that. I know a lot of the laptops are, of course, prepared to do virtual visits, and other devices are ready as well with the addition of a webcam and microphone. And so far to date, the approach has been a program one, in that, a program would identify if there are needs specific to equipment that people need to be able to do their work, and have kind of gone at it in that way. Um, but we are also at the task force level looking at, whether or not there should be more of a corporate-wide approach to supporting this, so that it's easier for people, and it doesn't have to be program specific and have people figure that all out. So I think that's going to be one of the things that we're looking at in the next week or so in more detail. One of the other questions was around, what are some of the plans to identify patients or populations in the long term with respect to virtual care. And so far, a lot of what's been done has been done on a case-by-case basis. So I talked a little bit about, the fact that people in different areas work in different ways. The requirements are different, patient requirements are different. And so a lot of this has been driven on a case-by-case basis and identified by yourselves as some of the frontline staff and providers and leaders and physicians in terms of what care might look like for their patient populations. And so generally speaking, we haven't taken an organizational wide approach yet on how that should be done, and who should be thought of first from a virtual care perspective. And we've really been trying to align it with what makes sense based on your feedback and information that you provide, and where you think it would be helpful. And so I think generally we continue down that road, with the exception of course, during the COVID time as well. There is a principle as a part of the ambulatory care task force, which Bruce also chairs, around doing visits virtually in the first instance, so that, or if possible, instead of bringing somebody into the hospital. And of course, that's related to patient and staff safety, PPE conservation, so on and so forth. And so, that's kind of the only broad direction related to virtual care. But other than that, it's kind of, where are the needs, and let's support people in addressing those needs and delivering value that way. One of the other questions that was sent my way as well was kind of around Wi-Fi and lags in some of the platforms. So certainly, I'm sure you've all experienced lags in Zoom calls and or OTN. And the question specifically was around whether or not the free Wi-Fi service was impacting this at all, especially at our HHS sites. And so I passed that along to our HITS group to look into that. And unfortunately, they didn't have a response for me for this meeting, but they've committed to looking into that more broadly. But there are some general guidelines or recommendations in using these kinds of video platforms as well, so as to enhance your experience using our devices at HHS. And so the first thing, and probably the most important, is that video calls like Zoom or OTN should be done outside of Citrix. And so if you haven't already, there is the opportunity to request through a MyIT HITS request to have a web browser installed on the desktop of your device. And your performance, your performance will significantly increase if you're doing it outside of Citrix. So that's a key consideration. The other thing with respect to that is Wyze devices aren't ideal for video calls either, because they are locked down to Citrix, so that can cause issues sometimes too. Uh, and I'm not sure what people's approach is generally if they're working at the hospital, if they're on our hospital, like our secure Wi-Fi platforms, or if they're on using the free Wi-Fi access. But certainly, if you're on the free Wi-Fi access using a device, I would encourage you to discuss with your leader the opportunity through a MyIT request to get on our secured networks, which typically would have better bandwidth. A couple other things, just keeping applications on your device to a minimum. So, don't have 50 windows open, because everything that is open can affect the speed of your device, of course. And we know too, in this day and age, with everything being done virtually, that some of these platforms are taxed as well. And so, that is, or our ability to address that is limited to a degree, because we can't control the performance outside of our environment. So whether it be OTN's performance or Zoom's performance, if they're having issues themselves, but certainly that could be a factor too. So I think, Bruce, those were kind of the main questions that were sent my way, and I'm happy to answer anything else, or if you have anything else to add, feel free.
Thank you so much, Nate. I think we're going to call it there so we can get a few more of the questions done, but really want to take this opportunity to celebrate and thank you for your leadership in driving us forward. And also, this is a celebration for this team. The reality is that what you've done with virtual care as one of the key tools over the past 3 months is protect a tremendous number of children, youth, families, adults from the absence of care, and we pivoted on a dime to move to working that way. Doesn't mean that there's not opportunities to improve, for sure, but it really is just amazing, spectacular what you've been able to achieve. And so I really want to thank you for that. And Nate's been a big part of that. So big thanks to him. But really it comes down to then you taking advantage of what he's built. So thanks, Nate, for joining us today. We'll put a follow-up here, and please don't hesitate to keep questions coming on this topic. I'm going to start moving and get through a few more things really quickly. I did want to start with several questions came in follow-up to both the worldwide events as it relates to protests about systemic racism in our society, and the appalling events in the United States. And also in relation to, I think, to some of the comments I provided. And, two of the questions, I have a question, how will Ron Joyce work on racism and discrimination? At the last town hall, Bruce, you addressed anti-Black racism. What will you do differently to commit to anti-Black racism? And so, let me start with personally, I struggle, and I look for your advice to know exactly what and how, and so I'm going to keep coming that. For sure, what in the immediate I've been doing is to make sure that I'm asking myself in every interaction and every situation, whether I'm explicitly trying to get at my own privilege and to get past my own privilege, to get past my own circumstance and think of others. I will say that I was pleased to hear and have been discussing with Rob McIsaac, and you may have just heard him today, that we are taking the Human Rights and Inclusion team at HHS, who are specifically devoted to this, are taking all of the advice they've received from you and other members of HHS, and they're compiling that into a very specific report with recommendations coming to the senior leadership team. So I'm really looking forward to that. I believe that some appropriate steps that we need to take is I'm going to look to ask experts from the inclusion team and with lived experience to conduct some workshops with our leadership team to help us to identify specific actions and activities. We're going to review our policies and procedures, particularly looking for that opportunity to, or that requirement to make changes in those policies and procedures to appropriately ensure that we're respecting diversity, inclusion, and equity. And again, we'll do that, but we're going to ask the experts with lived experience to do that as well. The other commitment I have to still make is to take advice from you. So I'd like to, going to invite interested individuals who are willing to step in to come together as teams to provide advice. I don't know, again, that sums up is I don't know all of the right actions. And I don't think our leadership team does either. But I think as a collective with individuals, particularly again, those of us with lived experience, we can learn and can identify what steps to take. So I look forward to more on that. The last thing, sorry, to take is, I know we've had a great webinar produced by Tina Garnett, but I'm also going to ask that she be one of our so Tina Garnett is the human rights and inclusion specialist at HHS. Going to ask her to attend one of these sessions coming forward to speak directly to us. So look forward to more discussion and more suggestions there. So gonna now start to go very quickly through. So people parking and screening. So I had a question about screening and parking. I have parking in South Garage and things are opening up and more people are coming back to work to walk down through the South Garage and then across the underground. It's becoming busier and at times almost unsafe as I'm having to navigate between cars while cars coming through the lot. Things set to become even busier and more traffic in these areas. I'm wondering if there will be more spaces for screening or changes to the screening for staff taking safety into consideration. You may have noticed on Tuesday of this week that we did readjust the lanes and the location of the screening booths as an initial step, and my sense is that did improve the safety. We are right now as well moving forward with a plan that will take us away from face-to-face screening for staff and will continue to rely on our self-screening apps. So as I committed to you previously, my goal is to move us to a much more streamlined process across this site. And so we're moving forward on that. And by the way, again, that, in my review, or in my view, and I think our leadership team shares that, recognizes and respects and indicates the trust and belief we have in each of you as individuals and professionals in your diligence in ensuring that you aren't coming to work when you're safe and you are taking the appropriate and necessary steps. Thank you for your reply regarding discrepant fees for access to the South Garage. I appreciate that transportation to and from the ward lot would pose a challenge. Once again, I realize the hospital relies on parking revenue. However, while we as a team deliver a sustained effort through this trying time, leadership must choose actions that speak louder than words. Show staff that we are valued as one unified team. Everyone in the South Garage should be paying Ward Avenue prices. Clearly, if we were all in this together, co-workers shouldn't be charged two different prices when parking next to each other. While it is very much appreciated that HHS strongly believes in its sorry, that's a second question I'll get to in a second. So that approach has been implemented temporarily to ensure that those staff who normally have to board a shuttle bus to come from Ward Avenue, which is a challenge, are able to safely attend work. And that it might be, we're ensuring that it's not problematic for issues such as social distancing. We're going to look at the existing process shortly. Honestly, I understand that perspective on on fairness and equity. I can understand another perspective in terms of where those folks normally are and what needs to be retained. So I value and respect, and that's why I'm happy to share that opinion. My sense is that the approach that's being taken, though still with great challenges, is appropriate, recognizing those individuals will very shortly be back to Ward Avenue, where they will have to travel. The second thing is, while it's very much appreciated, HHS strongly believes and to communicate to the province the pandemic pay should be provided to all our employees. Perhaps HHS can look within themselves to do the right thing and provide fair and equitable pay across the teams. You may have seen this, those that were on the call with Rob McIsaac a few minutes ago know that that was discussed somewhat extensively. Oh shoot, time's going fast. Unfortunately, we both do not have full guidance and direction from the province, and so have not yet been able to issue the pay to those that the province has deemed appropriate. In terms of others, we continue to advocate that it should go to all of our employees, but that is not what the province has been approved. And you may have heard there that it's our understanding, in fact, that the other legislation prevents us from doing something different than that. So there's going to be more to come on pandemic pay as we go forward. I recognize and agree, as really all of us do, that it should be made available to all of our members, and so we'll continue to push for that publicly. I'm so sorry we took 15 minutes with Nate, which I hope was of value, because it was on virtual care. I really believe it was. I got a lot less further with questions than I thought I would this week, and so I'm really sorry about that. I'm going to try to write these up, and we'll post them. I always want to make sure we do share for a second. So let me at the end, in terms of celebrations, I think we celebrated virtual care. Let me kind of well, I guess maybe it's not so much a celebration as a message to all of you. So I've said a few times that the Walk and Wheel is our most important fundraising event at the Children's Hospital and at Ron Joyce Center. It helps us and is critical to the acquisition of equipment, to our programs, and to our people, and to some of the positions we provide. The foundation is doing a wonderful job to pivot to COVID, but it's a challenging pivot. And so we've moved to the and I've just gotten the signal to do the draw. I'll do that too. So we've moved to the to a virtual approach, and that involves, again, the mascot dance video. I don't have time to show you it, but I did a dance video with my two daughters, and with Pepper and Coco, our sloths, and with the the foster ducklings that my family is currently fostering for a 2-week period. So I would really encourage you to go to the Walk and Wheel site to maybe that'll entice you to look at it. If you want to see somebody who can't dance, try to dance. But I really want you to go there so you can think about whether there's colleagues and friends that you want to refer this to, and to encourage them to donate. And if you yourself want to make a donation as well. This is so important to the amazing work that you do and to help to support that. Now, last thing, I do want to do the draw. And so our winners today, Miriam Kim, behavior therapist, Ron Joyce. So Miriam, Valerie Carroll, RN in our CF clinic. Congrats, Valerie. Congrats, Miriam. And Taylor Young in our pediatric emergency department. So you've each won. I'm pretty sure it's a coffee pack. I I hope I'm right there. I'm pretty sure that's what it is. So we'll get that word out to you as soon as possible. So with this, I'm really talking fast because I went over time. But thanks everybody for everything you do. Best wishes for Thursday. If you can't, if you can, do a little dance at some point. Just, a dance can, no matter how bad you are at it, it can make you feel good. I tell you, it made me feel good. So that's my little bit of wellness advice to help refresh. Do a little dance in person or in private. Sorry, in public or in private. Have a great day, everyone.